Hello, who is there from Grafakira?
Dr. Hunt should be there.
Yes, sir. Should I start, sir?
Good morning, sir. Good morning, everyone. Should we start? Sorry.
Yes, let's start.
Good morning, everyone. Today we are going to discuss a topic of PDA, Patent Doctor's Arteriosus. My topic, which I'm going to explain, is pathophysiology and clinical feature of preterm PDA. But before going to this particular topic, we should start from understanding what is PDA. So, PDA is most common type of extracardiac shunt. It represents persistent patency of the vessels after birth that normally. Sorry, sir. Am I audible?
Yes, you are audible. Please go ahead.
Sure, hang on. So it represents persistent patency of the vessels after birth that normally connects the pulmonary arterial system and the aorta in a fetus. So something about PDA. In utero, it carries most of the right ventricular output, around 60% to systemic circulation. But at birth, due to increased PaO2 and loss of placental prostaglandin, it causes to constrict the Doctor's arteriosus by 12 to 24 hours of life. But in preterm infant, the closure is often delayed or fails. So understanding of PDA in preterm is usually critical due to persistent left to right shunts that affect the hemodynamics. Now, before going to the pathophysiology, let's understand the normal physiology of Doctor's arteries or fetal circulation. So, the oxygen-rich blood from the placenta goes through the umbilical vein and it reaches gradually to IVC ductus flusus and which reaches to the right atrium. Now, the deoxygenated blood returns to the heart, right atrium from IVC and SVC. Most of the blood that reaches to left atrium via foramen ovale, leading to blood flow to the ascending aorta and which supplies the upper part of the body. Now, the remaining blood which comes from the superior vena cava and inferior vena cava reaches to the right atrium, to right ventricle and to pulmonary artery and goes to the systemic circulation via ductus arteriosus and supplies the rest of the body. Only 8% of the right ventricular output flows into the lungs, providing nutrients for the development lungs. Now, there are some of the factors that regulates the opening of the ductus arteriosus in utero. That is elevated intraluminal pressure due to collapsed pulmonary vascular plate. Second is prostaglandin, PGE2. Due to ductus smooth muscle extraordinarily sensitive to PGE2 and vasodilation by activating adrenaline cyclase. And the third is nitric oxide. Now, before going to the pathophysiology of PD in preterm infant, let's understand first how it closes in neural circulation. So, after the baby is delivered, umbilical cord is cut, and hence the placental circulation is stopped, and where the neonatal circulation begins. In neonatal circulation, there is the foramen ovale is closed and ductus arteriosus is closed, and the mechanism for this closure is after the first breath of the baby, there is decrease in pulmonary venous persistent with increase in pulmonary blood flow leads to increased left atrial filling, and there is closure of foramen ovale. And also there is increase in PaO2 and prostaglandin, with causes ductus arteriosus constriction, and later it closes, and hence the neonatal circulation begins. As deoxygenated blood is close to the IFC and UFC, led to the pulmonary vein, and oxygenated blood, which returns to the left atrium, to left ventricle, and goes in the systemic circulation. Now, there are some of the regulation which causes ductus arteriosus closure in neonates. That is, increase in PaO2, decrease in ductal luminal blood pressure. As described before, there is decrease in PGE2 due to loss of placental production and increased removal by lungs. Also, there is decrease in PGE2 receptor in ductus soil. As there is two closure, one is functional closure and another is anatomical closure. It's occurred in usually a term infant, occurs by 12-24 as functional closure and 2 to 3 weeks as anatomical closure. Now, there are some of the factors which causes patency of ductus arteriosus in preterm infant. Like in extremely immature neonate, there is decrease in intrinsic tone compared to ductus tone in term neonate due to immature smooth muscle. There is also calcium entry through L-type calcium channel also is impaired in immature ductus. There is reduced expression in function of oxygen sensitive potassium channel in immature ductus. Now, coming to the pathophysiology of PDA in preterm infants. As we have discussed, the factor causing the failure of closure of ductus arteriosus, which leads to shunting of blood from higher pressure, that is aorta, to lower pressure, that is pulmonary artery, and it causes left to right shunt. That causes increased blood flow to the pulmonary artery and increased blood return to the left side of the heart, which causes loaded left ventricles, leads to increased pulmonary vascular congestion and resistance, which further leads to right ventricle hypertrophy. So there is basically a pulmonary over circulation and systemic hypoperfusion. So pathophysiology which affects the particular organs, as the most common is lungs, that causes pulmonary edema, reduction in lung compliance, increased ventilation and oxygen requirements, that causes chronic lung disease and pulmonary hemorrhage. Also, it affects GI tract, which causes decreased mesenteric blood flow, GI injury, NEC, and local ischemia, leads to spontaneous intestinal perforation. In CNS, it affects the cerebral blood flow, as there is alteration in cerebral blood flow, and sometimes it also causes IVH. In renal, there is decreasing kidney function or increasing creatinine level. Now, a basic difference between term versus preterm. In preterm, the smooth muscle are less responsive to high PO2, and therefore it's less likely to constrict after birth. But early pharmacological can close PDA and spontaneous closure can occur. But in term infant with PDA, the wall of the ductus is deficient in both mucoid and endothelial layer, which causes persistent PDA. If there is PDA is persistent beyond the first few weeks of life in term infant, it rarely closes spontaneously or with pharmacological intervention. Now, coming to the clinical feature of PDA, as there is no symptoms seen in small doctors, but if there is large PDA, it can lead to exertional dyspnea, which can be seen as poor feeding. There is poor weight gain, recurrent chest infection, and the signs of congestive heart failure. In a ventilated neonate, we can get a clue if there is increase in ventilator setting, high FiO2 requirement, that is hypercarbia, or metabolic acidosis. It gives a clue in a ventilated neonate. These are some of the signs, as there is bounding and collapsing pulse. As we can see in PDA, there is systolic hypertension, which is due to higher left ventricular stroke volume, and there is low diastolic pressure, as the systemic circulation runs off from aorta to pulmonary circulation. Hence, there is wide pulse pressure, which is usually more than 25 mm of mercury. The apical impulses are also down and out. A thrill in a suprasternal nodes or in a left intrapleural region is palpable. The second heart sound is obscured by murmur, and there is also paradoxal splitting of S2. As there is masonary murmur, which is continuous and loudest in the second left costal space, in small infant, it is uncommon to hear the diastolic component of the murmur. Also, there is apical diastolic rumble caused by high flow through the mitral valve into a left ventricle and is audible in large PDA. Now, what is HSPDA? It is a hemodynamically significant PDA and is suspected when there is sign of excessive pulmonary perfusion, such as increasing PaCO2 and or alveolar arterial oxygen gradient. There is also decrease in lung compliance, and we are very hard to wean of the infant from supplemental oxygen, or there is distending airway pressure. Now, there are some of the concern with persistent PDA. As SGPGI, as I've already mentioned before, there is pulmonary overcirculation and systemic hypoperfusion, which leads to pulmonary edema, alveolar protein leakage, which leads to prolonged ventilation, and all it causes decreased compliance, which later leads to chronic lung disease. And in systemic, if there is systemic hypoperfusion, it causes hypotension, and in-organ hypoperfusion, which leads to IVH, NAC, or PPL. So there are some of the take-home messages, as the doctor's arteriosus is vital in fetal life, but after birth, it must close. Failure to close is especially seen in preterm infant. A persistent PDA creates a left to right shunt, which causes pulmonary overcirculation and systemic hypoperfusion. Hemodynamic significant, as we have discussed, is seen as continuous murmur, bounding pulses, tachycardia, and signs of heart failure. And always consider PDA in preterm baby with unexplained distress. Thank you.
Thank you very much, Dr. Hansh. May I request Dr. Anbarsan to kindly proceed with the next presentation on evidence for and against closure of PDA?
No, I can't able to sharing screen. Someone else sharing screen.
Dr. Hansh, you can stop sharing the screen.
I have problem in sharing screen.
Just hold on. Dr. Harsh is still sharing.
Okay, sir.
Harsh, Dr. Harsh, can you stop sharing?
Yes, sir. I am trying to.
Press escape. Yeah. Now go to Zoom.
Thank you, sir.
Yeah. Okay.
So, good morning, everyone. I myself, Anbarsan A. Today, my moderator of my topic is Dr. Akansha ma'am. So, I will be discussing on evidence for and against closure of PDA. So, PDA treatment preterm neurons. When to treat a PDA? Shall we treat all the hemodynamically significant PDA? No. So when to treat the PDA and whether to treat at all or with who, what to treat. So this is an important three questions that come in our mind whenever we are planning for a treatment of PDA. So why this dilemma always exists? Because PDA, as we see from the previous discussion also, that PDA in most of the time is closes spontaneously, especially the preterm neonate. So after we have to wait and watch for most of the conditions in stable neonates without any abnormalities or without any morbidities. So we have to wait and look for whether the PDA is closed spontaneously or not. So as we can see from this table taken from every the rate of spontaneous ductus artery closure among neonate who survive to 72 hours of age. Whereas in preterm in full term neonates, in most of the cases by day 4, there is a 100% closure, whereas at the time of discharge, there is again a 100% closure. Whereas in more than equal to 30 week of gestation, there is 90% closure on day 4 and it is 98 on the time of discharge. With 20 to 29 weeks, there is 45% closure on day 4 and 94% closure at the time of discharge. Whereas let's see from the at 24 to 25 week of gestation, the closure is 4% on day 4 and it is 54% at the time of discharge. So as we can see from the tables, most of the cases there is a spontaneous closure of the PDA occurring. So we have to wait for most of the cases until otherwise it is causing any troublesome or problematic while managing the neonate. So other problem with HSPDA causes morbidity, but benefit of the closure always unclear, and there is side effect of drugs that have been used for the closure of PDA, and there is lot of surgical concerns following the surgical closure of the PDA in the form of BPD, long-term outcomes, and post-ligation syndrome. So what are all the treatment options available for PDA? It is mainly classified as an conservative management, pharmacological treatment, and surgical therapy. So in the conservative management, what we'll do, mainly we go for a fluid restriction or optimize the ventilation, including permissive hypercapnia and diuretics. Whereas in pharmacological therapy, we will use the drugs that is cyclooxanase inhibitors, indomethacin and ibuprofen and paracetamol. And next comes in non-pharmacological management, that is surgical and transcatheter device closure, which is gaining success in the recent days. So management strategies in mainly in the closure of EDA, while coming to the pharmacological therapy, it mainly involves the following drugs and when is to close. That is the timing of therapy. It had its own three approaches, that is prophylactic approach, early targeted approach, and symptomatic approach. In prophylactic approach, treat all the high-risk babies who are having significant PDA in less than 12 hours, even before it produces symptoms. All the babies who are less than 12 hours, even before it produces symptoms, whereas early targeted approach, diagnose a large PDA within less than 72 hours and put a selective treatment for the closure of this PDA. In symptomatic approach, we will have to go for a symptomatic treatment. That is, in early symptoms, we have to go for treatment when the symptom appears on day 2 to day 5 of life. In late cases, we have to wait until second week of life, that is day 10 to 14. So this again an early targeted approach. In yearly target approach, I already discussed, the PDA closure has been attempted in less than 72 hours of age. So this is an trial which was done by Clarko et al. He has tried for an yearly target approach for closure of PDA based on the echocardiographic findings. This was published in Australian trial in 2014. He has enrolled eligible infant of less than 29 weeks, screened for large PDA, and received indomethacin or placebo before age of 12 hours. So what the study has to the evidence? It is feasible to identify the infant with large PDA early after birth with ultrasound and target the treatment to this group. So indomethacin treatment of large PDA before 12 hours of age reduce pulmonary hemorrhage and subsequent symptomatic treatment without causing the harm. So early cardiac ultrasound targeted treatment have no effect on the primary outcome of death or abnormal cranial ultrasound in this underpowered study. So, what are the evidence against routine closure of PDA in the preterm units? There are various trials which have described why to close, or what are all the expectant management or the yearly drug therapy which have its role, or what are the morbidities associated with it have been described. So, this is a Benedict's trial and PDA tolerate trial, and this is a Cochrane review. I'll be discussing one by one the subsequent slides. So Benedict's trial, this is a trial showing the expectant management of versus yearly brufen for treatment of patent ductus arteriosus. It is published in 2023 New England Journal of Medicine. Here they have enrolled 273 infants. The primary outcome was kept was NEC, BPD, and death in expectant management versus yearly brufen. The median gestation age was 26 weeks and median weight was 245 grams. And conclusion from the study, what they were told, expectant management for PDA in extremely preterm infants, it is non-inferior than the yearly proven group in the primary outcome of NEC, BPD, and death. So next comes the baby Oscar trial. This is again a trial which was published in British Association of Perinatal Medicine and Neonatal Society. Here it was done by Samir Gupta et al. In January 24 and 2024. So here what they have done. Here, the selective yearly treatment of patent ductus arteriosus with ibuprofen reduced death or bronchopulmonary dysplasia at 36 weeks in extreme preterm babies. It is a randomized control trial. They have randomized 326 neonate to ibuprofen and 327 neonate to placebo. There was no evidence of reduction in death or moderate to severe BPD in using ibuprofen for the early closure, but there is a reduced need for surgical ligation and higher proportion of closed and non-significant PDA. Next comes the Cochrane review. This is a recent review done by Souvik Mitra et al. Published in 2025. Here, what they have done in the study, yearly treatment versus expectant management of hemodynamically significant PDA for preterm infants. They were compared various treatment managements. 19 OCTs were included, total 2,323 participants published done in October 2024. From this study, what the authors have concluded, yearly or very early pharmacotherapeutic treatment of HSPDA probably results in little to no difference in mortality in preterm infants. However, very early use of ibuprofen may lead to moderate increase in the mortality in extreme preterm infants. Conversely, very early treatment of an HSPDA, lead to a trivial reduction in need for invasive PDA closure. So coming to this other findings of the study, early or very early HSPDA treatment may result in little to no difference in CLD, severe IH, and NAC. So very early treatment of an HSPDA also probably result in little to no difference in moderate to severe neurodevelopmental impairment. So as we can see from this, early treatment versus expectant management, each of it have its own advantages, own disadvantages. So they have concluded that further studies are done to detect the meaningful effect while avoiding the potential harm from their treatment strategies. And next comes a systemic review and meta-analysis, conservative management of patent ductus arteriosus in preterm infants, which was published in 2021 by Tim et al. In the study, they aims to evaluate the outcome after conservative management. That is no pharmacological and surgical intervention. They have done the treatment with fluid restriction, diuretics, and ventilator adjustments to the active treatment. They have enrolled 12 cohort studies and 4 RCTs encompassing 41,804 neonates and 720 patients. What they shown was from the result, there was no differences in mortality and morbidity for conservative management compared with active treatment regimens were observed in RCTs. Finding from the cohort studies mainly highlight lack of high quality evidence for conservative management for PDA in preterm infants. So this again IPA trial showing the use of a yearly paracetamol trial for the closure of PDA. It is an randomized control trial for yearly paracetamol to promote the course of ductus arteriosus in preterm infants. So in this, they have taken 9 units, they have randomized equally between the intervention and control group. The primary outcome was kept was intervention for PDA up to 5 days, and secondary outcome was ductal closure at 5 days, ductal size at 48 hours, ductal reopening, mortality, and significant morbidities. What they've shown from this study, the yearly paracetamol closure, yearly paracetamol closure helped in the closure of EDA in most of the cases and reduces the need for intervention up to 5 days. But it is in short-term data and it has its own safety, but neurodevelopmental outcome has been not yet resulted. So this is an again tolerate trial, an exploratory randomized control trial of treatment of moderate to large patent ductus arteriosus at 1 week of age, published in 2018, comparing the early routine pharmacological treatment of moderate to large period end of first week to the conservative treatment. They have compared the early routine pharmacological treatment to the conservative treatment, and that yearly pharmacological routine treatment does not reduce PDA ligation compared to the conservative treatment in this trial. So this is again a recent meta-analysis which was published in JAMA Pediatrics by Santoshi et al. That's in 2025. They have compared active treatment versus expected management of PDA in preterm units. So the primary outcome they taken was composite outcome of death at 36 weeks PMA and moderate to severe BPD at 36 weeks PMA and moderate to severe BPD, and secondary outcomes are IVH, PVL, and retinopathy of prematurity and necrotic enterocolitis. So from this study, they have concluded that this meta-analysis found active treatment of hemodynamically significant PDA during the first 2 weeks of life was associated with significantly higher incidence of death or moderate to severe BPD and with increased mortality compared with an expected management approach. So they have concluded further research is needed for revision of protocols for PDA management. So why routine closure often fails? Mainly, the many PDAs close or become clinically irrelevant with the maturation. So always there will be a medication risk that have been used for its closure, renal or GI perfusion problems, bleeding, oliguria, NSA with various drugs that have been used for the closure in the form of indomethacin and ibuprofen. So potential for overtreatment will occur and exposure to procedures without downstream benefit. So selective closure, who might benefit? Persistent HSPDA with a disease burden despite of optimized respiratory and fluid strategy, failure or contraindication to medical therapy, and late symptomatic PDA contributing to prolonged ventilation or feeding intolerance, and considering the center expertise and candidacy for device closure has been decided, so whom to go for in transcatheter closure or whom to go for a surgical closure. This is given by AAP in 2025. So medical therapy. So I will be medical therapy will be discussed in the subsequent slides. There are 3 therapies that are available, that is ibuprofen, indomethacin, and paracetamol. A comparable closure efficacy to indomethacin with better renal and GI profile. IV or oral regimens are available. Monitor the urine output, creatine, platelet, and GI tolerance. So this is an Cochrane review on a role of ibuprofen as a prophylaxis. They have concluded that ibuprofen for the prevention of patent ductus autism preterm and low birth weight infants, ibuprofen probably decreases the risk of ED and D3 and D4 while it was used for the closure. But conclusion, it has its own advantages in the form of complications, that is NEC, gastrointestinal hemorrhage. So it has to be always compared whether to use or not, or how to decide when to close or what to use. Medical therapy, indomethacin in selected cases, effective ductal constriction but higher risk of renal, GI, cerebral perfusion effects will be seen with indomethacin. Considered when ibuprofen is unavailable and the risks are acceptable. Some centers use prophylaxis of IVH with separate protocols. So this is an use of indomethacin, Cochrane review on 2010. They have shown that indomethacin has prophylaxis for closure of preventing and mortality and morbidity in PDA. So preterm units, prophylactic indomethacin, short-term benefit in decreasing the symptomatic PDA and surgical ligation and severe IVH, but there is no effect on mortality and neurodevelopmental outcomes. So whether the indomethacin is effective or not is again a Cochrane review in 2020 through. They have compared indomethacin versus placebo, and they have shown that in the review of 14 clinical trials, indomethacin is very effective in closing PDA, reducing the risk of PDA being open at 1 week with 70% when compared to no treatment or placebo. So this is again a Cochrane review. They have shown that indomethacin for symptomatic patent ductus autism preterm was published in 2021. So they have shown that indomethacin is effective in closing a symptomatic PDA compared to placebo or no treatment in preterm infants. Medical therapy, again acetaminophen, that is paracetamol, similar closure in many trials, useful when NSAIDs are contraindicated, oral or IV dosing protocol access, and evidence-based growing, considers an alternative or rescue therapy whenever the previous treatment fails. So paracetamol is effective. This is again a Cochrane review for patent ductus arteriosus in preterm and low birth weight infants, which was published, which was done in 2018. They have shown that PCM as effective as ibuprofen and indomethacin. Neurodevelopmental outcome, no difference between PCM and ibuprofen. So pharmacotherapy, All the three drugs are effective in closing PDA. Ibuprofen is a drug of choice, better safety profile than indomethacin. Oral ibuprofen better than IV route, high dose better than the standard dose as proven by the recent Cochrane evidences. PCM neurodevelopmental outcome is uncertain. Evidence against the closure, as we see from the various trials, Benedictus, expectant management is non-inferior compared to the early closure with ibuprofen. BB Oscar, there was no difference in the death and severe BPD while using ibuprofen for early closure. Tolerate trial, early routine pharmacological treatment is not superior to conservative management. So these are all that various trials, they have shown that whether to treat or not. So when to stop the medical attempts? Whenever after the 1 to 2 course of medical therapy, if there is no desirable effect has been achieved or there is an adverse effect, we have to stop the medical therapy for further use. If PD remains hemodynamically significant and clinically burdensome, exclude to the interventional evaluation in the form of surgical management. In coming to the few points on late term and late preterm PDA indication for closure, mainly in term and late preterm, so there is an symptomatology due to hemodynamically significant PDA in the form of tachypnea, poor weight gain, LV dilatation or volume overload in the echocardiography and pH, and audible significant murmur with evidence of left to side overload considered for disclosure. If it is a silent, very small PDA, observe rather than routine closure. So transcatheter closure is preferred if anatomy allows. Surgery for unsuitable ducts or very small infants. Excellent success rate and short rigor with the transcatheter closure. So this is an compiled tabular column for closure and against closure. In preterm, early routine closure, none proven or major outcomes. Considered only if it is hemodynamically significant PDA with a morbidity for closure. For against closure, there was no benefit versus expected management on death, BPD, NDC, IBS, and neurodevelopmental abnormalities, higher drug exposure. So we have to decide when to close it or not. In preterm selective closure of PDA, persistent selective closure has been achieved in the following cases. Persistent highly hemodynamically significant PDA, despite of optimized care, failed and contraindicated medicines, and device closure is feasible in most of these cases. So against closure, there is a risk of renal and GI adverse effects, procedural risks, and may close over the time in some of the cases. In term and late preterm PDA, mostly the symptomatology and echocardiography findings and some audible significant shunt to go for a closure, especially the transcatheter cutaneous closure. Whereas in silent, very small PDA, always observe. So there's an algorithm for a preterm PDA closure and a late and a preterm PDA management. So these are Indian guidelines for indication and timing of intervention for congenital heart disease. I've taken the PDA closure in 2091 from Annals of Pediatric Cardiology. Intervene if the baby is in heart failure in case of small PDAs, because small PDAs may close spontaneously. Approved drugs are indomethacin, ibuprofen, and paracetamol. Mode of drug administration, intravenous or oral. At least 2 courses of drug therapy should be tried before considering surgical intervention. Surgical ligation if above drugs fail or contraindicated. Feasibility of device and coil closure of PD has been demonstrated, but risk of major adverse event is high. Prophylactic indomethacin or ibuprofen therapy is not routinely recommended. So surgical ligation is reserved for failed and contraindicated medical therapy. Declaring use due to complications and transcatheter closure is gaining these advantages because it is preferred and higher success rate and safer in extremely low birth weight babies. It can be used as weight as more than 700 grams. So these are the interventions for patent ductus arteries in preterm infants and overview of Cochrane review. This is published in 2023. I think 16 Cochrane reviews. We compared 130 randomized controlled trials, and they have summarized the evidence in intervention for treatment of PDA. So what they have shown from this Cochrane review, prophylactic indomethacin decreases IBH, but does not appear to affect the composite outcome of death or moderate or severe neurodevelopmental impairments. Prophylactic ibuprofen marginally reduces the IBH, while evidence is very uncertain on the effect of prophylactic acetaminophen on IBH. Oral ibuprofen appear to be more effective, and high dose is also found to be more effective, as I already told. So guidelines from AAP 2025, what they were told, no prophylactic treatment for significant PDA, wait and watch in most of the cases for its spontaneous closure. Conservative management always comes first. Routine closure of PDA less than 72 hours is not recommended because of its morbidity associated with this closure. If hemodynamically significant PDA passes for more than 2 weeks, go for a pharmacological closure. Ibuprofen is preferred. If it is on failure, then go for a transcatheter closure, preferred over a surgical closure. So take home messages. Hemodynamically significant PDA, it is a spectrum ranging from physiological aspects to and pathological variant resulting in various morbidities and mortality in the neonate. Prophylaxis is most often not always useful. Ibuprofen is the first drug of choice that can be used for closure. Oral higher dose is better. Paracetamol is promising, but it has a long-term effect is unclear. So always shift from the conservative management to the selective treatment and then transcatheter closure if it is needed. So when not to treat a PDA is always clear, but when to treat is still unclear. So do not treat all the PDA. Do not treat PDA in asymptomatic baby on the basis of echo only. Do not treat PDA based on the size only. Look for additional markers. So we have to select the suitable candidates probably based on the gestational age, phenotypes, and clinical and echocardiographic findings. Thank you.
Yes, your slides are visible,
Yes.
but it has again gone.
Good morning, everyone. I'll be discussing the echo-based medical management. So, echocardiography is the gold standard for diagnosing PDA. It has a critical role for diagnosing hemodynamically significant PDA and evaluation of therapeutic responses. So, the role of echo is in defining an HSPDA, which involves PDA shunt assessment and its impact on systemic and pulmonary circulations, myocardial and mitral valve function evaluation, and clinically relevant characteristics that modify the effects a shunt may have to an already compromised milieu. So there are three parameters. First is the ductus arteriosus characteristics, which are ductus arteriosus size, the shunt direction on color Doppler, and the Doppler flow pattern across ductus arteriosus. Then we see the assessment of pulmonary overcirculation, which is by the volume overloading of the left heart, as we have already discussed. LA by AO ratio, which will be discussed in the subsequent slides. Increased LPA diastolic velocity, mitral EA ratio, and left ventricular function. And then is the assessment of systemic hypotension, which is by the postductal aortic blood flow pattern and by the Doppler assessment of the blood flow in various arteries of the abdomen, brain, as well as the descending aorta. So, according to the AAP criteria 2025, HSPDA is a combination of clinical and echocardiographic parameters. In clinical criteria, it should fulfill 2 out of 4 criteria. First is the high CPAP or NIV with high FiO2 requirement or high ventilator settings at any FiO2. Second is hypotension needing a vasopressor. Third, persistent oliguria or renal dysfunction. And fourth is abdominal distension, feeding intolerance, poor growth, or history of NEC. Then coming to the echocardiographic criteria, should fulfill at least one criterion. First is the minimum PDA diameter of more than 1.5 mm, unrestricted PDA left to right shunt with velocity less than 2 meter per second, left-sided volume overload, and decreased or absent or reversed diastolic flow in the abdominal distending aorta. So the important views for PDA, high parasternal view and suprasternal view, which are the most important, I'll be discussing in the subsequent slides. And another views are apical 4-chamber and 5-chamber view and parasternal long axis view. So the high parasternal ductal view, the probe is kept at the 2nd to 3rd intercostal space in the right infraclavicular parasternal region, and the pointer is towards the 11 to 12 o'clock position. So we can see a three-legged stool appearance, the right pulmonary and the left pulmonary artery forming the right and the middle legs, and the duct forming the third leg. Then coming to the suprasternal view, the probe is kept in the suprasternal notch, pointer at the 12 to 1 o'clock position. So as we can see in the suprasternal view, this is the ascending aorta, this is the arch of aorta, and this is the right pulmonary artery. We can see the 3 branches of the arch of aorta. This we can see the PDA between the pulmonary artery and aorta. So ductus arteriosus patency can be seen by the high parasternal view, which we have discussed. The color Doppler, there is a bright flare of color seen. Then coming to the size, it is the narrowest point, which is measured usually at the pulmonary end, and which is measured in the 2D imaging view and not in the color Doppler view. So the types are small is 1.5, less than 1.5 mm, medium 1.5 to 3 mm, and large is more than 3 mm. The direction of flow, which is seen by the pulse wave Doppler, and the sampling gate is the pulmonary end of duct. So there are three directions. First is the left to right, which is usually established by the 12 hours of life. It rises gradually. Prior to the closure of duct, the velocity rises and there is a red jet of flow seen. So this is the left to right shunt. Coming to the right to left shunt, which is never treated, we can see the right to left shunt in the Doppler, and the bidirectional shunt where the pulmonary and aortic pressures are equal. It is right to left in the systole and left to right in the diastole. So this is the bidirectional shunt. Coming to the PDA flow patterns, first is the growing pattern, which signify decrease in the pulmonary vascular resistance. It is a bidirectional shunt with left to right predominance. Second is the pulsatile pattern, which is pure left to right shunt. It has a higher velocity in systole and lower velocity in diastole. And the closing pattern, continuous high velocity is seen. There is lack of pulsatility and it is suggestive of constricted PDA. So the pulsatile pattern is treated. Coming to the markers of pulmonary overcirculation, it is LA by AO ratio, which is seen by the Plex view, EA ratio by the apical four-chamber view, and IVRT by the apical four-chamber view. So as we can see, we put a M mode in the parasternal long axis view, and we see the diameter of aorta at the end diastole and LA diameter at the end systole. So if the ratio is less than 1.5, it is mild. If it is 1.4 to 1.6, it's moderate, and it's more than 1.6, it is severe. EA ratio, the ratio of the velocity of the early diastolic phase of ventricular filling versus the late atrial contraction component. We create a four-chamber apical view and put the pulse Doppler on the mitral valve opening. So as we can see, this is the EA and EA ratio. In preterm infants, due to the immaturity of myocardium, the ratio is less than 1. In significant PDA, left atrial pressure increases and EA ratio also increases. In the moderate PA, it is 1 to 1.5, and in severe PDA, it's more than 1.5. Coming to the IVRT, isovolumetric relaxation time, it is the time between the closure of aortic valve and the opening of the mitral valve. At this PDA, earlier opening of the mitral valve is there due to the high left atrial pressure. So IVRT decreases in the presence of significant PDA. In moderate, it's 3 to 45 milliseconds, and in severe, it's less than 35 milliseconds. So as we can see, this is the E and A, and this is the IVRT. Coming to the systemic hypoperfusion, it is generally seen by the left ventricular output, which is calculated in ml per kg per minute. The flow direction in one of the following postductal artery, which is the descending aorta, ciliac trunk, and absent or middle cerebral artery, anterior and middle cerebral artery. So the left ventricular outflow is, for this we need the aortic valve diameter and the velocity. And the formula is aortic cross-sectional area, the VTI, heart rate divided by the weight. So the pathophysiology is that the ductal left to right flow is there, which leads to the increased pulmonary blood flow, increased LV preload, LV and LA dilatation, and increased pulmonary venous pressure. So as we can see, the aortic velocity time integral is calculated by the 5-chamber view. The pulse Doppler is placed at the start of the ascending aorta, just above the aortic valve towards the aortic side. So we calculate the aortic VTI by this, and by the Plex view we calculate the aortic diameter at the aortic root. So if the left ventricular output is less than 200, it's normal. In 200 to 300, it's moderate PDA. And if in large PDA, the output is more than 300. Coming to the diastolic descending aortic flow, we high parasternal view with Doppler sample gate distal to the PDA. So in panel A shows the forward flow and in the diastole in the absence of PDA. Panel B shows absent diastolic flow and panel C shows reverse diastolic flow in significant PDA. Also, we see the QP by QS ratio, which is the right ventricular outflow ratio versus the left ventricular outflow. If it is 1:1, then it's antegrade diastolic flow. If it is absent, it is 1.3, it's absent diastolic flow. And in retrograde diastolic flow, it's 1.6:1. So the Doppler patterns in various arteries. We see the normal pattern, which is the positive flow in the systolic and diastolic phases. In moderate ductal stele, there is absent diastolic flow, and in severe ductal stele, there is reverse diastolic flow. So this is the summary of the echocardiographic parameters of ductal hemodynamic significance. As we can see, the PDA diameter, the PDA Doppler velocity, the left ventricular outflow, LV by AO ratio, EA ratio, and then the systemic stele, abdominal aorta, and celiac or aorta VTI ratio. Thank you.
So Vadia. Next is Vadia, right? Surgical management. We have two more lectures remaining now: surgical management and PDA management in term babies. Anyone from Vadia?
मेल कर देना, मतलब मेरा अपना वो है बोलना, क्योंकि ये नहीं तो ये स्किप हो जाएगा.
And Radhika, we can't hear you. Can you?
Dr. Radhika, you are not audible and you can switch to slideshow mode. Hello? Hello? If there are certain technical issues at your end, then maybe we can come back to it later. Someone from MRR can present and then you can sort it out.
Radhika or Boshmi, can you just confirm once?
She is having some issue with her laptop. Her mic is not working. Can she present?
No, but we can't hear her, no?
Yeah, she is having some issue with her mic.
So how?
So what are you suggesting?
What are you suggesting? Solution? We cannot hear her, right? So mic issue.
Can she present after the next session?
Yeah. Sure. We can. Yeah. Perfect. Ritika, can you do it? Radhika, please stop sharing the screen. Ritika can go from MRR.
Yes, sir. Is the slide visible?
Yes, but you need to switch to the slideshow mode. Full screen is not visible.
Is it now?
No, not yet. We can see the introduction slide, but not the full screen.
You have to share as a full screen. When you choose options, share. I think you need lecture for. I think we should play this video demo at every lecture. Everyone struggles with this. So share. When you click share, select the full screen, or you select the presentation. Then it should go on. There are options. It will allow you to choose. So stop sharing and again start sharing. So stop sharing in the Zoom. You have to go back to Zoom, stop sharing, and when you share, read what you're selecting. Select the full desktop. Everyone, I think, should practice this before presenting. Your online device is working. You should click on the Zoom link, do a prior play, like trial session. Everything about audio, video, sharing full screen, all has to be done prior to starting this class. We should not waste everyone's time. This is for everyone. I think this is a universal problem. Go to full screen. No, you're
Meanwhile,
not.
I think Dr. Radhika has posted that she's ready to share, so probably we can
Okay.
ask her to try. So, Dr. Radhika, if you can stop sharing, and Radhika, you can start sharing.
Okay.
Radhika, are you going to share? Please be prompt. It's already 9 o'clock.
Yes, ma'am, sharing the. Am I audible now?
Yes, you're audible. But you need to again switch to full screen.
Yeah, I'm just.
No, it's the same problem. We cannot see the full screen.
Yeah, everyone should know their device well. You can always try with yourself logging onto the phone and then see if you're able to see before the lectures. Everyone, I think, should do that. All the speakers.
Is it okay to start? I've done slideshow, sir.
We are not able to see the slide. So just do next. At least the slides are moving. Can you go next?
Yes, I'm
No,
doing
the
that.
slides are not moving. Okay, now they're moving. So maybe we'll have to do it without the slideshow. Just do it like this only then.
Okay. So my topic is surgical management of
patent ductus arteriosus. So indications for surgical management is persistent significant PDA. Indications of medical management fails to after 2 courses of pharmacotherapy, and contraindications to medical therapy like NEC, GI perforation, or renal impairment. So types of surgical management are percutaneous device closures and surgical ligation.
Radhika, your slides are not moving.
So percutaneous, first is percutaneous closure. So absolute contraindication for percutaneous closures are Eisenmenger syndrome with irreversible elevated pulmonary vascular resistance. Relative contraindications are very large duct, there is no suitable device for that, and associated pulmonary vascular stenosis or coarctation of aorta, weight less than 6 kg. It is an indication of surgical management, and it is a silent PDA. So what are the devices available for surgical percutaneous closure? So first is coils. There are 3 types of coils available in Giantrico coil, neat occluded coil, and Cook detachable coils. These are the 3 available coils. So these are the these coils came in different variety of sizes. They are usually made up of stainless steels and contains fibers to increase their thrombogenicity. So coil occlusion, they are highly efficacious and cost effective. These are the MRI compatible coils, and these are the coil of the choice. Complication associated with coils are failure to implant, coil embolization, residual leak, persistent hemolysis, and duct recanalization. These are the complications associated with the associated with coil. So these are the devices available for PDA closure. So amplitizer piccolo devices, they come in various sizes. So this is the ADO type 2 amplitizer duct occluder. This is self-expanding. There are 2 symmetrical discs available with diameter is 3 to 6 mm. So this is amplitizer duct occluder 1 and 2 are MRI compatible devices. So this is the amplitizer vascular plug 2. This made up of multi-layered nitinol. Diameters available are 3, 4, 6 mm, and they are stiffer and stiffer retention cable is available in this, and they are used for PD ligation. And third is the Medtronic microvascular plug. This is nitinol cage-like framework covered by PTFE membrane. So before the device closure, the angiographic view is shown in picture A, and after devices, the angiographic image is shown in B. So third is next is surgical ligation. There are 2 we can do by 2 ways. Posterolateral thoracotomy. So incision is taken through the 3rd intercostal space in infants and 4th intercostal space in the older children. And the B is video assisted thoracoscopy surgery. It is safe and effective than posterolateral thoracotomy. So contraindicators indications are ductal diameter more than 9 mm, previous thoracotomy, ductal calcification, active infections, and ductal aneurysm. These are the contraindications. So complications associated with surgical ligation are pneumothorax, chylothorax, infection, laryngeal palsy, and post-ligation cardiac syndrome, bleeding, and more. They can cause BPD, retinopathy of prematurity, and neurodevelopmental impairment. So most common syndrome associated with PDA ligation is post-ligation cardiac syndrome. It refers to the physiological changes that can occur following the closure of PDA. It is typically after 4 to 12 hours of the surgery, and sudden increase in the afterload and decrease in the left ventricular preload occurs following ligation, putting the neonate in high risk of decreased cardiac output. So it presents with the increased need of inotrope oxygen support and worsening ventilator requirements. So a proposed algorithm for post-ligation management is what we do before ligation. So preoperative echo to determine the PDA severity, routine preoperative blood workup, and ACTH simulation test to assess the stress response of the baby. So in after post procedure, 1 hour after post-op, we need to do post-operative echo to determine the LVO, volume, support, and milliradian comments if LVO is less than 200 milliseconds per kg per minute, and ventilation is wind off as a tolerated, and continuous blood pressure monitoring, and avoid vasopressors. If there is a hypotension, if systolic BP less than third percentile and diastolic BP is more than third percentile, we need to give volume support, support with inotrope like dobutamine, and consider hydrocortisone to increase the systolic BP. If diastolic BP is less than third percentile and systolic BP is more than third percentile, we need to give volume support, and inotropic support will be dopamine, and can give hydrocortisone. If both diastolic and systolic BPs are less than third percentile, we need to give volume support and hydrocortisone. So there are clinical trials available. So PDA closures, surgical closure or device closure. So there are 12 studies available in less than 2.5 kg babies. So 12 studies, 966 babies are included in transcatheter percutaneous closure group, and 3,700 included in surgical group. So what we have seen that hemodynamic instability is in the transcatheter percutaneous closure group, and there is no significant difference for the outcomes of the BPD or major complication not seen. And third study was that the prophylactic surgical ligation of the patent ductus arteriosus of prevention of the mortality and morbidity in extremely low birth weights. This is the Cochrane study. So outcomes are death within the 28 days of life, death till the 1 year of surgical, grade 2, grade 3, grade 4 IVS, severe NAC, bronchopulmonary dysplasia, retinopathy, and only one study is available for this. And third is association of the association of PDA ligation with death or neurodevelopment impairment in the extremely preterm infants. Conclusion of this study is compared with the medical management, surgical ligation of the HSPD is associated with lower mortality without increased risk of CLD, ROP, or NDR, or the composite death of the death or neurodevelopment income. Thank you.
Thank you, Dr. Radhika. Dr. Ritika, you can start. Dr. Ritika, are you there? Hello, anyone from MRM? Dr. Ritika?
Yes, ma'am, I'm joining.
Yes.
Is it visible?
Yes, but not full screen, but I think you can start.
Now is it there?
No. We cannot see the full screen, Dr. Ritika, but you can check if your slides are moving. Maybe you could present like this
Try
only.
do this 2-3 times. Just now you did. Yeah. Yeah. Now we can. Please start.
Yeah, so PDA in term neonates. Clinical overview and management. So definition of PDA is that's the most common type of extracardiac shunt. It represents the persistency patency of vessel that normally connects the pulmonary arterial system and aorta in fetus, remaining patent in the postnatal life. So role of ductus arteriosus in fetal circulation is vital for bypassing the lungs. And normal postnatal closure mechanism after birth, it should close on its own, but in PDA it remains open. So PDA, is it beneficial, a bystander, or harmful? So fetal circulation we have discussed. Unlike PDA in premature infants, spontaneous closure of a PDA is rare in full-term infants and children. This is because the PDA in term infants results from a structural abnormality of the ductal smooth muscle rather than a decreased responsiveness of the ductal smooth muscle to oxygen. So there is controversy existing for defining persistent ductus. In term neonates, usually it closes rapidly. In a study in 2014, 56% had no transductal flow at 12 to 18 hours, and 96% had no transductal flow at 30 to 40 hours of age. Whereas closure in ductus in VLBW babies vary. Even closure in preterm less than 28 weeks, in 50% of cases, PDA closes spontaneously without treatment. Incidence in term neonates is low, with estimates varying from 1 in 2,000 births to approximately 1% of term neonates, and a prevalence rate of around 81 per 10,000 live births. This is significantly lower than in preterm infants, where PDAs are far more common. So risk factors are maternal rubella infection, birth at high altitude, premature birth, female sex IUGR, ductal dependent lesions, presence of pulmonary hypertension, genetic factors like in genetic syndromes like Down syndrome, Holt-Oram syndrome, incontinentia pigmenti. So for systemic to pulmonary shunt, there is systemic hypoperfusion, leading to effects on cerebral blood flow, ductal steal phenomena. The risk of IVH and poor perfusion in term neonates is less. Effects on gut blood flow. Ductal steal may cause feed intolerance, but less likely to cause NEC in term neonates. Then effects on renal blood flow. Renal failure may occur. Lower systemic BP, blood flow, and poor perfusion, leading to metabolic acidosis, lactic acidosis. So increased volume of shunt causes pulmonary flooding. Increased pulmonary blood flow causes increased oxygen requirement, ventilation support. Pulmonary hemorrhage causing respiratory morbidity or mortality. Cardiac dilatation and CCF. Clinical features are symptoms severity depending on degree of left to right shunting, and it is determined by the size of PDA, ductal resistance, cardiac output, as well as systemic and pulmonary vascular resistance. Tachypnea and tachycardia may be present in infants with CHF, continuous murmur, hyperactive precordium, systolic thrill, bounding pulses, wide pulse pressure, heart failure signs, and differential cyanosis. Diagnosis can be confirmed by echo. Chest X-ray may show cardiomegaly and increased pulmonary vascular markings. ECG may show left ventricle hypertrophy. Management remains same, but in term neonates, role of medical management is limited. So closure of duct may need transcatheter closure or surgical ligation. Also, medical management can have multiple complications like intestinal perforation, hepatotoxicity, platelet dysfunction, and renal toxicity. So this is the transcatheter device closure. Various new devices. So there is a concept of ductal dependent lesion in case of term neonates. PDA is critical for survival in some congenital heart disease, which are termed as ductal dependent lesions. So circulation, pulmonary, systemic, or mixed circulation, they may rely on PDA patency. So closure of PDA in these cases may lead to acute decompensation or death. Ductal dependent pulmonary circulation, lesions with inadequate pulmonary blood flow, like in pulmonary atresia, critical pulmonary stenosis, tricuspid atresia, or severe tetralogy of Fallot. In these cases, PDA supplies the pulmonary arteries and helps in maintaining oxygenation. So ductal closure in these cases may lead to profound cyanosis and hypoxemia, and closure can be rapidly fatal without intervention. Ductal dependent systemic circulation, lesions with systemic blood flow obstruction, examples HLHS, critical coarctation of aorta, interrupted aortic arch, or critical aortic stenosis. In these cases, systemic perfusion depends on right to left shunting across PDA. So PDA closure may lead to shock, metabolic acidosis, or death. In mixed lesions, lesions requiring the mixing of oxygenated and deoxygenated blood for perfusion. In case of transposition of great arteries, PDA provides additional site for blood mixing along with ASD. So PDA patency improves oxygenation and helps for survival until surgical intervention can be taken up. So management implications, prostaglandin E1 alprostadil infusion initiated immediately to maintain ductal patency in these cases, so that we can stabilize the infant before surgery or catheter intervention. Definite treatment would be surgical shunts and corrective surgery or catheter-based intervention. In these cases, early recognition is vital. Undiagnosed duct-dependent CHD presenting after PDA closure will be a neonatal emergency. So PDA and PPHN, high pulmonary vascular resistance is seen in case of PPHN. So there is right to left shunting via PDA for bypassing the lungs, which lead to systemic hypoxemia. But even though it causes a systemic hypoxemia, PDA also acts as a pop-off valve for right ventricle. In cases of severe PPHN, it helps unload right ventricle load. Prostaglandin E1 infusions can maintain ductal patency in these cases, which helps in improving oxygenation despite the systemic hypoxemia and reduces acidosis and supports the RV function. Not all cases need PDA patency. Only in cases of severe RV failure, we can keep PDA open. But if there is adequate oxygenation and RV function, then PDA can be allowed to close, or even we can induce closure. Similarly, CDH preoperative cases where PDA is getting smaller. So individualized approach is essential for taking a call for PDA patency. So PDA in term IUGR babies, term IUGR infants have higher risk of PPHN and PDA. There is chronic fetal hypoxia and placental insufficiency, which leads to pulmonary vascular remodeling in cases of IUGR babies. There is reduced pulmonary vascular bed development at birth, which results in elevated pulmonary arterial pressures. So in our 2020 study, 33% of IUGR neonates had pulmonary hypertension on echocardiography, where ductus may remain open. Incidence was significantly higher than in non-IUGR peers. Meconium aspiration syndrome also contributed to some cases, but IUGR itself is an independent risk factor as it has fetal programming of pulmonary circulation. Clinical implications are that IUGR babies require careful cardiorespiratory monitoring. If PPHN develops, PDA due to right to left shunting may cause differential cyanosis. So for management, we optimize oxygenation and pulmonary vasodilation by ventilation, surfactant or INO use. We can also consider prostaglandin even infusions if ductal patency is needed to support the right heart. Once stabilized, PDA usually is not a sustained problem. The main issue in these cases are high pulmonary pressures. So management, when and why to treat a PDA. So we have to assess the significance of the PDA. In term infants, an HS PDA is typically defined by evidence of volume overload, and a small asymptomatic PDA may be followed conservatively for a long time. Indication for closure is in term or near-term infants when any moderate or large PDA with signs of heart failure or pulmonary overcirculation should be treated. If infant is difficult to wean off respiratory support or has a failure to thrive due to a PDA, then therapy is indicated. Sometimes even asymptomatic PDAs are electively closed if they persist beyond a certain age to prevent the late complications of PAH or endarteritis. Timing, there is some variability, but many experts will attempt medical closure if a significant PDA is identified in the first day or weeks of life. If a ductus remains open beyond 6 to 8 weeks despite conservative measures, it is unlikely to close spontaneously, and definitive closure via catheter or surgery is usually pursued. Early closure within first 3 months for large PDAs has the benefit of avoiding prolonged volume load on heart and lungs. So prognosis, small PDAs may close spontaneously. We have to identify the high-risk infants with a hemodynamically significant PDA. Long-term risk of cardiac failure, pulmonary hypertension, or infective endocarditis. But the long-term outcomes are excellent with treatment. So to summarize, PDA is rare in term neonates. Treatment is generally surgical, but it improves the long-term outcomes. In ductal-dependent lesions or PPHN, ductal patency is useful. Thank you.
It looks like a lot of people leaving now. Any final questions, summary? I think good presentation and good coverage by everyone. Any questions, comments? I was about to ask that what practice for PDA management, medical management, every unit practices, but I don't think we have time left now. It's almost 9:30. Girish sir is there? Girish sir also has left. Yeah, I mean, we would have had some discussions. Anita, what do you suggest?
Yeah,
I
we'll
think we
take a
should wrap up.
time. We
Yeah.
should wrap up.
All right. Okay then. Thank you. Thank you, everyone. Thank you. Bye.
Thank you, everyone.
Bye. Well done, everyone. Bye.